up on that. David Schwartz has shown in his series that deciding on when to remove the ceton with the guidance of an rectal ultrasound is helpful in terms of having successful removal of ceton without perianal sepsis. Do you do that at all? Do you think there may be added value in that, or in most patients it doesn't seem necessary?
We do not routinely do that. I think there is probably a subset in which there's, when there's a question, there's added value. But we haven't studied it, so I can't say for sure, but we do not routinely do that. My clinical experience is that you can you have a gut sense that this is epithelializing, and so the tract has got enough fibrosis so that it's going to stay just a tract and not have an associated cavity with it. And the people who have an associated cavity often have sort of hypertrophic granulation tissue around the ceton and some more induration than you'd expect. And those people we would study before we took the ceton out.
And can I ask you about the occurrence of fistulas in ulcerative colitis patients post-J-pouch, perianal fistulas, that is? We see that phenotypic switch to Crohn's disease. Some don't appear to actually have Crohn's, but have something else. We don't really know what. Are you using ASCA testing? What's your view of how to maybe predict those patients or ward that off, or what are the factors that predispose to that?
I think that there are two groups of patients who get fistulas after J-pouch and done for ulcerative colitis. It's not uncommon if you do a contrast study of a J-pouch prior to closing an ileostomy that there's a sinus tract from the anastomosis, and which is a technical issue or sepsis issue. They may not have clinical sepsis, but you might see just a little wisp. And there's a lot of debate about should you wait to close the ileostomy or not. But regardless of whether you wait, then you close the ileostomy at some point. And we are seeing 8 or 9 years out that those patients may develop a perianal fistula in the same place that they had the sinus tract. So why then and not immediately after we close the ileostomy, I have no idea. But there is that subset that I think it's not a matter of their underlying disease process, but it's some sort of chronic infection that blossomed again for whatever reason. Then there is this subset that tend to look like Crohn's, and we have not found the serologic testing to be very useful. And we sculpt them and biopsy them and study do CT enterography and do everything we can to try to prove that there's some evidence of Crohn's disease. And because our gastroenterologists are reluctant to treat them too aggressively medically without a specific diagnosis, although that's changing because now they're using many of those same medicines for pouchitis, so then it blurs that line. So, but there's a group that we just treat their sepsis locally and put cetons in. And we could do all these other operations. They don't work very well. Pouch vaginal fistulas are particular problems. The lift procedure that I described, this transection of the fistula tract, there's some appeal to trying that because it's a very simple operation. But there isn't any data about it. And what there's data about in terms of pouch vaginal fistulas is big muscle interpositions, and even they don't work all the time. So we typically, in that subset, have put cetons in and sort of waited until the disease shows up. But I don't have any way of predicting, other than that finding of a sinus tract on their gastrographin study, which I don't think predicts the Crohn's-like stuff.
On the infliximab and ulcerative colitis surgery, I think it's helpful. Most of the studies are relatively small, but in the UK, anyone who receives an anti-TNF is compelled to join a registry. So they have data on tens of thousands of patients, and including all patients, including RA, but they've shown significant increases in wound infection after surgery that decrease if it's more than 2 weeks after the anti-TNF, and approach background after 4 weeks after the anti-TNF. So that suggests there may be some value in timing. That you shouldn't be giving the anti-TNF on the way to OR.
Right.
You can get at least 4 weeks out, there may be some
Yeah,
value.
I think the American data is, it's too hard to interpret that, but what was included in those series from Cleveland and the Mayo Clinic is within 12 weeks. So whether if they looked at that more closely, they didn't have that. They did have trouble.
Yeah, they didn't have enough numbers.
They didn't have enough numbers to do a subset by the time, right?
In addition to the timing, I was also wondering what your sense is of the reason attorney was spent use. Was it like a last-ditch effort? Because in those situations, it makes sense that patches would be followed by adverse events.
It's not, no, those are not patients who are all with like toxic colitis who are hospitalized and getting treated, because I think there are many reasons in that subset of patients that you would expect more complications, particularly nutrition. I think one of the problems with the aggressive continued last-ditch efforts is that many of those patients are malnourished when they come to the OR. But this is taking all patients who, and the Cleveland study is looking just at elective.
I'd like to thank you all for coming and thank our sponsors.